morning. This is a very special event today. I want to start by first thanking Dr. Sarah Shumway for being here and joining us today. You and your family's support and participation in these visiting professorships is so meaningful and impactful and greatly valued by the entire department. And we will hear more about your particular involvement in bringing this particular visiting professor to Stanford the first time. So I also want to thank our organizers, Maggie and Ruth. They work tirelessly on all of these events and deserve so much credit for making these absolutely perfect. We last held this visiting professorship in 2018, 6 years ago. And that was given by Dr. Edward Stinson, who, together with Dr. Shumway, did the first adult cardiac transplant in the United States right here on this campus. That was also a celebration of the 50th anniversary of that operation. So indeed, that's a high bar. And we, as a faculty group, decided that virtual visiting professorships really did not have the same impact of the real event. We've all participated in them either as speakers or as attendees, and they really don't have the same feeling. So we decided as a group that we would simply not have any visiting professorships during the entire COVID pandemic and afterward. And so we really just restarted this a little less than a year ago. And so for the Shumway, we thought, well, it's going to be a really hard act to follow of Stinson and the 50th anniversary as we sort of re-engage. And there's no other person than Vaughn Starnes who could live up to that bar. So Dr. Starnes is a world-renowned congenital cardiac surgeon and adult cardiac surgeon. He has an eponymous operation for Epstein's disease. He invented low-bar lung transplantation. I'm describing some of these because I'm not sure our young residents are going to read this pamphlet, and they may not know all of the details. And he's also a tremendous pioneer in the Ross operation, which you'll hear a lot about. I think the most important thing about this aspect is that what he's done is taken a very, very complex, involved, finicky operation and made it highly reproducible, one that many of us can go ahead and do, and we've all learned a lot from Dr. Starnes on how to advance the Ross operation. Dr. Starnes is currently, and has been for quite some time, the chair of the entire Department of Surgery at USC. And so not only does he have the cardiac and thoracic surgeons and congenital heart surgeons in his realm, but all of the colorectal surgeons and the endocrine surgeons and all the fun that comes with it. He also rose to prominence as the president of the Western Thoracic, and most importantly, he became the AATS president in 2020, a very difficult time for the world, but also for the AATS, which was undergoing a major transition in its management structure and overall organization. And Dr. Starnes spearheaded this tremendous transformation of one of our most prominent and prestigious organizations in the entire world. So with that, Dr. Starnes, we welcome you back to Stanford, and we're so grateful that you are serving as our Norman Shumway visiting professor.
Thank you, Joe. Sometimes it's better just to close your slides and go home after the introduction. It's really truly my honor to be here today, given the 12th Dr. Norman Shumway visiting professorship, and returning to Stanford. It's like returning home. I left about 32 years ago, but it doesn't seem like it's that long ago until you walk on campus and you don't recognize anything. Obviously, Dr. Norman Shumway was my mentor, but more than that, he was my friend. His voice still echoes in my mind every day when I walk into the operating room with my residents. Some of the things that I remember most is he loved being called the world's greatest first assistant. And things like, you can never learn to be a surgeon unless you operate. You can't read about it, you can't watch it, you gotta do the cases. And I try to mimic that every day in my training program, those sage advices that he gave to me. He's will always be a legendary figure in cardiovascular surgery for being the father of heart transplantation. But to me, he'll always be my mentor in my career. I really have nothing to disclose, and so to sort of begin our lecture, just for the residents in the audience, talk a little bit about history. I think what we do today was really started with Dwight Harkin, with the placement of the first valve in the subcoronary position. He had to obviously wait for the heart-lung machine to be invented, but his original description is much like we do today with conventional bioprosthetic or mechanical valves that we use. His was a mechanical cage ball valve that Al Starr and Edwards really perfected, and a lot of these were used in 1967. Over 2,000 of them were used, and I think when I first came to Stanford, some of the faculty were still using the old Starr-Edwards valves. But if you look at that valve and what we'd like to think of an ideal valve, you would think of a valve that had no resistance to forward flow. It would be laminar flow. It wouldn't leak. Would not damage any of the blood cells. No thromboembolism. Should resist wear and should produce no noise. It should be quiet. And when I talk about no thromboembolism, that's no thromboembolism without anticoagulation. So these are the choices of valves today. I'll just quickly run through those. Mechanical bioprosthesis autograft that we're going to talk a lot about. Percutaneous valve is something that's being done now very widely, and a lot of it's exceeded the number of surgical valves today that we implant. But obviously it's out of the scope of this talk. This is the mechanical valve that most of us have been using over the years. It's Abbott or St. Jude valve. It has good flow patterns. It's low profile, but it does require anticoagulation. It has a risk of bleeding and thromboembolism. And a lot of things that people don't understand, it is a valve that you can hear click. A lot of times this is overlooked, but when I sit with patients, particularly young patients, I bring this up because some of them are in professions that would rather not hear the clicking, such as attorneys in a quiet room. And I'll make sure that they understand that this valve initially will be heard. These are the tissue valves. Very popular valves now are the bovine pericardial valves, the new Edwards and Spears valve that have the rings that can be dilated for the percutaneous valves, the TAVR valves to be inserted later. But when I think about the perfect valve, I don't think there is a perfect valve, but you'd like to think of a live valve that you could put in that would be able to repair itself. So if we're thinking about the Ross procedure, what are the questions that we should be asking ourselves? Well, I think we want to look at really the outcomes of porcine versus Ross, porcine versus mechanical, and really the life expectancy of individuals that have these valves. Tyrone David published in 2016 sort of analysis of his Ross versus mechanical AVR. And you can see on the right-hand side of this slide, I think on your left-hand side, if you look at the freedom from cardiac valve-related mortality, you see over time the two curves start to separate out. And at about 10 to 12 years, obviously the Ross procedure is now exceeding mechanical valves in terms of survivability. And down below on the left-hand side, you can see again the but anyway, you can see the anticoagulation-related issues start out immediately with the Ross procedure being superior to the mechanical AVR. Doesn't mean the mechanical valve is not a great valve. It is a good valve, but looking at the data, the quality of life seems to be favoring the Ross procedure. Here's another survival curve that got my attention out of Australia, American Journal of Cardiology. And you can see even at 10 years, the separation of the curves of life expectancy between the mechanical valve and the Ross procedure. And that 20 years is substantial, 97% versus 68% survival rate. These were in very young patients, I think less than 35 years of age. So some pretty convincing evidence that the Ross might be the better valve to put in particularly young patients with life expectancy greater than 15 years. And this was Hamze looking at the New York and California registry data. And you can see mechanical bioprosthetic valves, there's a constant hazard function, and the risk of mortality goes up over time as compared to the Ross procedure, actually for age and for race, matches the general population at the time. So I think this is one of the outcomes slide that I think is really impactful, particularly for young patients receiving an aortic valve. Well, this is a slide that obviously is the recommendations by the American College of Cardiology and Heart Associations about valve recommendations. Class 1 recommendations is that you sit and talk with your patients about valve choices. And I think that's done very, I wouldn't say rarely, but I don't think it's done in great detail, because often you have a patient coming into your office as surgeons with them being told already the type of valve they should get without any consultation. I think it's incumbent upon us as surgeons to sit, talk with the patients about the sort of the 3 valve options out there, particularly if they're in the young age, say less than 50. You've got mechanical, you've got bioprosthetic, and you've got and the center that does then the Ross procedure. I think it's important to do that, because a lot of the patients that come in today are fairly uninformed about their choices. And you can see on the left-hand side of the slide the 2A recommendations. Again, if they're less than 50 years of age and there's no risk for anticoagulation issues, they recommend a mechanical valve. And if they have issues around 50 to 65 years of age, and again, mechanical valve they say is a reasonable choice versus a bioprosthetic valve. And then if you're greater than 65, now the bioprosthetic valve becomes the valve of choice. And then, believe it or not, down below there, the Ross procedures finally talked about in patients less than 50 years of age if they do not want to be on Coumadin, and you're in a center that actually does the Ross procedure. Well, something that I think is very important for us to remember, Dr. Ross did not describe the Ross procedure initially. It was described here on campus by Dr. Shumway and Lauer in 1960. In a paper published in the Journal of Thoracic and Cardiovascular surgery, autotransplantation of pulmonary valve into the aorta. So the history of the Ross procedure begins here on campus at Stanford. Again, a landmark paper that Dr. Shumway and his colleagues published. I don't think it's along the parallels of Christian Bernard, but it was something that was not quite recognized by Dr. Shumway in his contributions to the Ross procedure. So obviously Donald Ross gained notoriety for this operation out of Guy's Hospital in London. He transplanted the pulmonary valve over into the aortic position. He also makes a comment you can do it in mitral position, which is done some in places. I've done 8 or 10 of them in young women. But he popularized this operation. And I think one of the things that we forgot initially here in the States, he did it as an inclusion in the aorta, whereas we popularized it here in the States in the late 90s, early 2000s as just a sort of a Bentall implant without being supported. And as we know, over time, those dilated and became insufficient. And the popularity of this operation waned because of that. So in looking at the unique features of the pulmonary valve, I think one of the things that we have to remember, it's a viable autograft. Its cellular mechanism is able to repair itself. The tensile strength, as it's been looked at, is 2 to 3 times that of the aortic valve leaflets. And this really means that if implanted correctly, it has long-term durability. It's got great hemodynamics because it opens up very anatomically out of the way of any flow restriction. And in children, I've documented this. It will have somatic growth as the child grows. It's the only valve I know that will do that. I've implanted them in as early as a 1 week old, 2 week old. We've followed them out now for 20 years. They don't become aneurysmal, they actually grow with the child. But at the time of implant, the pulmonary valve is usually 3 to 4 times larger than the aortic valve annulus, so you have to do a cono to make that work. And of course, there's low risk of thromboembolic events without any anticoagulation. So as you think about doing the operation, and I've gone over this with my own faculty, you're operating out of your comfort zone a little bit. And that's true even with experienced surgeons as you begin this operation. I think to do it intimate familiarity with the root replacement operations. I think in evaluating particularly young patients, you can have anomalous coronary anatomy. You have to have coronary imaging to make sure you know where all the coronary anatomy might be. Sometimes you have interluminal coronary left veins coming in. You have anomalous takeoffs of the right coronary artery. And it's particularly among bicuspid aortic valves, you often have a lot of coronary anomalies. One thing you have to keep in mind in doing these operations, and I know Joe wants to talk about this later on, but it's the impact to the right ventricle. One dose of cardioplegia, you might be in trouble. I think you have to be really particular about protecting the right ventricle because it does get warm under the lights, and if you're not cooling the patient dramatically, it does get warm, and RV failure can be a common problem after the Ross procedure, particularly if it takes a long time to do it. So you have to keep thinking about RV and LV protection during these operations. I believe the inclusion technique helps make this procedure very reproducible. It becomes now basically a Bentall procedure with a composite graft. And looking at who's the ideal candidate, this is just some of the patients I think about. I think of those individuals with active lifestyles, the young individual who wants to go skiing with his family, people who are outdoors, they like to go hiking. I think these are perfect people for the Ross procedure. Athletes, women of childbearing age. I have used it in patients with aortic valve endocarditis where we did not have a big annular abscess. And in patients who anticoagulation is obviously contraindicated and not desired. This is particularly among children. It's very hard to anticoagulate a child. Some of our kids have had mechanical valves that come in with head bleeds because the INR gets to be 15, even the best of management circumstances. In children, again, I think the issue with prosthetic valves is the lack of growth of the valve, and they end up getting a lot of pannus formation. Mechanical valves in a child will mechanically work for a long time, but underneath they have pannus formation for 5 to 8 years, and you've got to go in and change the valve out. I think with the Ross, with the ability for it to grow, because in a child less than 10 years of age, I never put a inclusion jacket on it because the pulmonary valve is often very durable and will not become aneurysmal in those children. So we allow it to grow over time. And obviously it's a valve that has long-term survival rate in the position. You do have to contend with the pulmonary homograft or the pulmonary substitute that you placed, but I think that's a much less severe operation than changing out the old aortic root. Well, contraindications, obviously we have an abnormal pulmonary valve, but I will tell you I've used a bicuspid pulmonary valve in 2 occasions and it worked out fine. Those occasions I didn't have much choice otherwise. I think if the patient has a life expectancy less than 15 years, I don't think this is a big operation you should undertake. I think a bioprosthetic valve in that circumstance is just fine. Connective tissue disorders, I haven't used it in Marfan's. for example, immune complex diseases, or severe endocarditis involving aortic annuli abscesses or involvement of the mitral valve. If you look at the age distribution of people coming into your practice, people less than 30 years of age usually have a bicuspid aortic valve that's calcified or it's regurgitant. From 30 to 70, you're looking at usually a mixture of calcified congenital bicuspid valves. Less than 50 years of age, over that you start getting into sclerotic and acquired valvular heart disease, and obviously over 70, you have degenerative disease, usually due to calcification and acquired heart disease. It's amazing to me that this has been proven now with the percutaneous valves that 3% of the patients over 75 years of age with aortic valve disease have critical aortic stenosis. And I think that's the reason we're seeing so many TAVR valves go in today that we may have not operated on in the past, and now they're getting the percutaneous valves. Even in the 90s, people are getting these percutaneous valves. We're cleaning out the nursing homes, I think. Tongue-in-cheek there. This is sort of the practice guidelines that I use. It's obviously practice dependent. I think age is a crucial deciding factor for the choice of operations. In the 20 to 50 years of age group, the large root, good leaflets, I'll do a valve sparing operation. Large root, bad leaflets, obviously I'm a Ross guy, so I'll do a pulmonary autograft inclusion technique. 50 to 70 years of age, large root, good leaflets, valve sparing again. Large root, bad leaflets, I do a Bentall operation, usually a BioBentall. And over 70, it's a Bentall operation versus a TAVR. I think these are general guidelines that work in most of our practices. I think it's good rules of thumb. I think we should try to preserve the valve anytime we can if we've got leaflets to work with, and we just really dealing with the dilated aortic annulus, and they're really good repair techniques. More and more today with a non-calcified bicuspid aortic valve, people are repairing it and getting great results. So I think repair and salvage of the aortic valve anytime we can makes sense to me. So I'm going to steps-wise go through the Ross procedure as I do it. So I begin with the heart totally arrested. I usually take out the coronary buttons. Usually there's so much calcification, I think it's important to try to get the calcium out, but I usually take out the buttons first and then take out the valve. I can just see better that way. You have to be a little careful with the left coronary location during the enucleation. Sometimes it's intramural. Again, emphasizing bicuspid aortic valve often has other associated pathology, particularly proximal aortic aneurysms, coronary anomalies. So I think to study the valve and the coronary anatomy and the aorta preoperatively, I can't overemphasize. Again, we just take out the aortic valve. It's usually heavily calcified. You have to take it out in a way you don't distort the annulus. I think that's particularly important using the technique I use, which is a running suture at the annular level. I try to really take it out very carefully to preserve the annulus as much as possible. And then I transect the distal PA first, and in the beginning, I recommend that. You can look back across the pulmonary valve and sight on the infundibulum of the right ventricle where to make your transverse incision. It usually comes out about a centimeter and a half below what you think is the pulmonary valve leaflets. I would just say it's better to err lower than higher because it's amazing how quickly you can get into the pulmonary valve and do this first incision. And then start the enucleation process. Those in the room have done this operation. There is a distinct plane between the RV outflow tract and the pulmonary valve. That if you get into the right plane, you'll be above the first septal perforator, and this valve then enucleates out very nicely. As I've got an arrow here, that's very close to the LAD, so you have to be careful when you come around to the left side of the pulmonary valve. Always look posteriorly I think transecting the PA first, you can lift the PA up and see the left main, see the course, then of the LAD very clearly. I think that's important in order to preserve the LAD without injury in the first septal perforator. So when I get the pulmonary valve out, I try to measure it. I measure it by echo before I take it out, so I've got some idea of the size of the valve. And then once I've sized it, I usually pick a 2 to 3 millimeter larger size Dacron tube. I will tell you, a lot of people around the world now are using the Valsalva graft. I have not done that. I'm not saying it's not a better way of doing it. I've just decided to do it this way because I can get better, I think, alignment of the sinuses and the commissures using this particular graft. I think it's critical as you do this horizontal mattress suture at the bottom, attaching the autograft to the Dacron tube, that you try to get the same distance between the skirt and the sinuses all the way around. That way it lines up the commissures in the beginning. I think this is critical to get the loop alignment. Once you've got this sewn into position with the horizontal mattress, you've everted the muscle, and it's easy to grab that muscle then along with the Dacron tube as you're sewing it into the area of the annulus. Then I obviously cut off the graft to match the height of the autograft. I put in 3 pexing stitches at the commissures. I usually do this at 5-0 with the oval pledget just to make sure I secure it. Then I run the top with usually again a 5-0 suture. Test the valve, look like they've got commissure alignment, make sure the sinuses approximate before I sew it in place. Then I check the harvest site. I'll use handheld cardioplegia at this point, get cardioplegia down both coronaries, and particularly looking at the bed on where I've harvested the pulmonary valve, because there'll always be some bleeding back there, and now's the time to take care of it. If you go ahead and sew in the homograft and you've got bleeding back there, it's hard to control once the heart is beating and you're trying to rewarm. So I try to take care of any bleeding at this point in time in the operation. And again, it's a good time to get cardioplegia. Then I bring in my composite graft. It now looks like a standard valve inside the graft. I run the first layer with running through proline, attaching the composite graft to the aortic annulus. I think it's important to grab the annulus all the way around. I do sort of cheat near the conduction system, go a little higher to avoid heart block. And once I've got it in place, of course, you need to line it up in the beginning. I make sure I get left coronary alignment with the sinus, and sometimes the right coronary, given the sort of 180-degree alignment of the coronary buttons, it's a little hard to always get that right, but I think it's usually comes out just fine. I make my hole for the coronary button. I usually make the autograft hole much smaller than the Dacron. That way I can see the autograft clearly as I'm sewing in the button to the autograft. I do put in a felt backing onto the coronary button to match up to the Dacron tube, so that really does prevent bleeding as we're coming off bypass. One of the things that in putting on the right coronary button, I will put a suture in the right ventricular outflow tract. I'll elevate it such that it moves everything into the right anatomic position, such I know exactly where to put the right coronary button. If you don't do that, you're sometimes thinking that it's more to the non-coronary sinus than the true right coronary sinus of the graft. So I would encourage you to put that stitch in, pull it up, and that way you can sort of see the orientation of the right button to the composite graft. So once I've got both coronary buttons in place, I actually go back and put a piece of native aortic tissue in the non-coronary sinus just to approximate it and hold that sinus in place to the Dacron tube, such that all 3 sinuses now are fixed. I think that makes it a more stable graft. It, I think, helps prevent prolapse of the leaflets. The ones that I've seen fail over time have been a prolapsing non-coronary sinus, and I think it's due to that non-supportive sinus. So I started doing this about 10 to 12 years ago, just again learning from past mistakes, if you will. So this is a video of a case that I did. It was a 40-year-old attorney. You look in, he had a pretty nasty valve. As you can see, he had proximal aneurysm. So this is all done with the heart arrested. So I've taken the coronary buttons out, I've divided the distal PA, and now I'm taking out the autograft. Again, the right coronary is back out of the way. I don't have to worry about that. Sometimes there's large coronal bridges that come across. So here I'm coming into the left coronary system. I'm looking over and see the coronary artery there. That's sort of the white, sort of gets blanched out by the lighting. And then you're going to see very clearly here there's a plane between the right ventricle and the pulmonary valve. These little sort of blunt tip scissors, you can get into it and just scoot along the pulmonary valve there. And then once you got that, you can sort of roll the valve out right on top of the first septal perforator you see up there. That very white vessel is this first septal perforator. It really rolls out very nicely. Measure it out. It's like the native average is 27. I think the pulmonary valve is probably 26, 27. So I'll probably put this in the 30 millimeter hemoshield graft. So again, I tried to make sure I get the coronary sinuses lined up at the same level or circumferentially around this graft. It starts basically getting me a nice valve that's very competent. I try not to bunch the sinuses. I try to make it equal all the way around. So now I'm going to amputate the graft to the height of the autograft. Again, taking the pulmonary valve out, one side of the pulmonary valve is going to have a little longer pulmonary length than the other, so I'll amputate that down again to get the height of the commissure is the same. Make sure it's competent. I've sewn it in place with the running 3/0 Bowling. Test it again. So this is the implantation of the left coronary button. I'm still sort of awed with Dr. Liu's description of taking this pulmonary valve out on a beating heart. I find it, let me try that just to see. You know, compare and contrast. So I like this felt button. It really makes it very hemostatic. You don't need bleeding back here. It becomes a bit of a problem. And now that I've tested the bed where I've harvested the pulmonary valve, it should be pretty dry now once I come off bypass. So this, I've put a stitch in the pulmonary outflow tract. I've pulled it over now. I've sighted the place where the right coronary button should go. And selecting the pulmonary homograph, which I always use, I don't use forcing valve or anything. I like the pulmonary homograph because it fits very nicely. I always use the largest one I can find. It's either 27, 29, or 30. This is completed pulmonary homograph in place, dearring. So this is a paper that we reported in 2021 of only bicuspid valves. A lot of them had proximal aortic aneurysms. And at 10 years, the unwrapped, which was the failure mode of the Ross procedure when it was not supported either in the aortic wall or with inclusion technique, 25% of them had problems that we had to go back and re-repair, and that's usually with the David. That's how the whole inclusion technique came to mind. If I'm doing a David at that step, I'm going to just do a David in the beginning. And then we looked at our recent series, only about 3% had to be reoperated for autograft issues, 10 years. So a dramatic difference, 25 versus 3%. And these were age matched, with death being competing outcomes. At the adult center, we've done over 450 of these. I've done about 300 at the Children's Hospital, so my total experience now is about 750 patients we've had lost procedures now. So obviously, I'm a believer in the lost procedure. I think it's a great operation. A lot of the patients have come back 20 and 30 years now. It's what happens when you're an old surgeon. You can see these patients in long-term follow-up. Obviously, the problem that there is here is the pulmonary homograph that we use, but a lot of, particularly the adult population, it goes 15, 20 years without any problem. Now with our ability to do catheter interventions on the pulmonary valve, I think this makes it even a more favorable operation. Thank you.